A very warm welcome to you and thank you for joining us on Health and Wellness. My name is Zaitun Ali, and on today's episode, the topic of discussion is children living with diabetes. And right here in studio, I'm joined by Dr. Phoebe Wamalwa, who is a pediatric endocrinologist. Yes, I got it right?
Yes.
Yes, a pediatric endocrinologist, together with Emily Mankura, who is director for Action for Indigenous Children with Diabetes Kajiado. Karibu sana. We also have this young champ over here. He's called Charles Sitat, who is a diabetes champion. And today we're just going to discuss about the whereabouts of this disease and how to manage it. Welcome to the show.
Thank you so much.
And I'd like to start with you, Daktari, just to create more awareness about what is diabetes.
Okay.
Yes.
Thank you so much, Zaitun. Let me start by explaining or describing what diabetes in general is before I could perhaps go to the different types of diabetes. So what's diabetes? Diabetes is a condition where we have persistent high glucose levels in the body, and it could come about as a result of lack of insulin or resistance to the action of insulin, or both. So that's how we define diabetes in general.
Okay.
But now when you look at the types of diabetes, we have many types, academically speaking. But when, for the purposes of this show, I just want to focus on two types and perhaps just mention one in passing, since we're talking about diabetes in children. So we have type 1 diabetes, type 2 diabetes, and I'm going to talk about neonatal diabetes just briefly.
Okay.
So what is type 1 diabetes? So type 1 diabetes is the type of diabetes that affect mainly children and adolescents and young adults. Mm-hmm. And it occurs as a result of deficiency of insulin in the body, as a result of destruction of the cells in the pancreas that secrete insulin. So what is the pancreas? The pancreas is a small organ just next to the stomach that performs several functions, and one of them is to secrete insulin. So when 80% of the cells that do secrete insulin have been destroyed, then the child can develop symptoms of type 1 diabetes. Okay. Type 2 diabetes largely affects adults, and it is as a result of resistance to the action of insulin in the body. But majority of patients do not just have resistance to the action of insulin, they also have some level of deficiency of insulin. So that's why you'll find that these adults will be put on both oral pills and also insulin as part of therapy. The neonatal diabetes is diabetes that occurs in children who are largely less than 6 months of age.
Less than 6 months?
Yes, and for these children, then the management is not just insulin. We consider other types of management besides insulin.
Okay.
Yeah.
Okay, so probably for this case, Sitat, how are you?
Fine.
How have you been?
I'm good.
How are you feeling today?
I'm okay.
Yeah, so as we're talking about diabetes, could you just paint a picture to us, probably the symptoms that you were experiencing before diagnosis, before when they were ambulance, this is now diabetes, what were you feeling?
I was thirsty.
Uh-huh.
I was visiting the washroom frequently.
Uh-huh.
Yes, and I was tired.
You're feeling tired tu kila saa. Ukienda kucheza pia unasikia?
Yes.
Uh-huh. And shule, ulikuwa unaendaje?
I will go. The teacher was talking to mom when the sugars are high. Even when they are low, mom communicates, yes. Then mom taught me how to inject myself the insulin.
Okay, so you used to inject yourself insulin when the sugar is now low?
No,
when it's high. So when it's high, how are you feeling? That thirsty?
Yes.
You wanted to go to the washroom almost every single time?
Yes.
So where were you injecting it, and probably what are the instructions you were given?
The hands.
The hand.
Yes.
Okay. Mwalimu alikuwa anakusaidia, ulikuwa unafanya peke yako?
No.
Huko unaogopa?
No. I was confident.
And at what age were you when you actually discovered that you have diabetes?
I was 4 years.
You're 4 years old.
Yes.
Oh no, that's like PP1.
Yes.
Okay. How else did it affect your school life?
There's a time my sugars dropped and I was outside the classroom. So when I was walking, I fell down. I bumped my head.
Oh no.
Yes.
Iska yenye uko nayo hapo?
Yes.
Oh no. Pole.
Yes.
Okay. And any other time that you can remember? Apart from that, how did you come out of that? Who helped you?
The teachers.
The teachers?
Yes.
And then you were taken to hospital?
Yes.
So hospital visits for you were very frequent? In
Yes.
and out, in and out?
Yes.
How did that make you feel?
Bad. I wasn't happy. Yes. I was feeling like very different from other students.
Yeah.
Yes.
Au akienda kucheza?
Just sitting in class or sleeping.
Okay. So you are not even doing any kind of sports?
No.
And now how old are you?
Now I'm 16 years.
16?
Yes.
Hey, umekuwa mkubwa na ukai. Umeficha miaka wapi? How has it been since now, the 4 years old until now that you're 16? How has it been? How have you been managing it?
I've been just following the doctor's instructions.
Okay.
And I've accepted it. Now I'm just okay.
Wow. That's a very powerful comment. You've
Yes.
accepted it. Okay. So medications uko nazo kila siku?
Yes.
How many times a day?
3 times.
3 times.
Yes.
And you never miss. Unakuanga on schedule, na uko na schedule unajikumbusha kila saa.
Yes.
Okay, that is good. Okay. Emily, and I'd like to engage at this point. I know you're doing amazing work for these young children uko Kajiado. So Sitat pia ni wa Kajiado?
Yes.
Okay. Ulianza aje, mlikuja kujuana aje na Sitat, and how did we start with this?
I personally am a champion for diabetes
Okay.
for 33 years. I got diabetes when I am 3 years old.
3 years?
Yes. So by kuwa champion ndio nilipata nini ya kuja kutafuta watoto pia kuwasaidia and show them that there is still life. Yeah.
Time yako hizo 33 years, how was it? Ulikuwa na manager aje?
It was not easy because parents hawajasoma. They don't know what is balanced diet. They don't know how to inject you when you are cautious. So it was hard. Several times admitted in Kenyatta Hospital. The time I was diagnosed, I was unconscious. So nililetwa Kenyatta.
Yeah.
Nikalazwa for 3 months in ICU.
3 months
Yes.
in ICU.
Yes.
Yako ilikuwa type gani ya diabetes?
Type 1.
Ilikuwa type 1.
Kama triacetate. So hapo ndio nilijulikana, nikaanza kutumia dawa pia kujidunga. Haikuwa rahisi. Maana familia hawajui. My mom hajaenda shule. She's a widow. So safari hiyo maisha is not easy. Okay. Yeah.
Emily, let me ask. Now that hata unasema ulipelekwa Kenyatta. Hospitali kwani Kajiado, what was happening?
By then nilikuwa natibiwa kwa private hospital. So where they don't understand about diabetes, they don't have knowledge about diabetes. So walikuwa natibu pneumonia, malaria. So again tukuwa tunajua sana mambo na referral ya Kajiado. So tuliletwa hospitali kwa private hospital, then wakasema hawaniwezi, wakanirifa Kenyatta. Yeah.
Okay.
Yeah.
Okay, it makes sense sasa. Daktari.
Yes, please.
As they are speaking about the symptoms, could you just elaborate more on how this disease portrays itself?
And I'm so happy actually hearing the story of Sitat and Emily.
Yeah.
Sitat mentioned that he was feeling thirsty and passing frequent urine, and he was weak. Now, I want to explain how the typical symptoms of type 1 diabetes come about. We said in type 1 diabetes, we have deficiency of insulin. What does insulin do? Insulin acts as the key that pushes the glucose into the cells. So once glucose enters the cells, it's metabolized into energy. So that's the energy that gives us strength to move around and, operate normally. But because this glucose is not entering the cells, it will accumulate in the blood system. The kidneys would want to remove it from the body. And as it gets removed from the kidneys, it drags along water. So that's how they have frequent urination. As they are urinating frequently, they develop dehydration.
Okay.
So because of dehydration, they will naturally feel thirsty, so they want to take a lot of water. And remember, glucose has not entered the cells. So the cells are starving. So the body has to find a way of getting alternative energy. So how does it get alternative energy? It breaks down the fat cells, it breaks down the muscles, it breaks down the stored glucose in the liver, so that it can get what? Alternative energy. So because of the breakdown of this fat and muscle, the patient will lose weight. So now the 3 classical symptoms of type 1 diabetes is frequent urination, a lot of drinking of water, and weight loss. So for those of us who are in the community, if you find a child with these 3 typical symptoms, take the child to the hospital and let him or her be tested for for blood sugar. In the event that these 3 symptoms are not picked out early and the diagnosis of diabetes is not made early, the breakdown of fat cells will continue to an extent that the body now develops a lot of acidosis, because fat cells will be broken down into what we call ketones. Now, when ketones accumulate so much in the body, the patient will feel nauseatic, will feel like throwing up, vomiting. They may actually now start having loss of consciousness, and because of too much acid in the body, they have labored breathing. If intervention is not done at that particular time, they may go into coma, just like Emily explained. So a number of our patients will be diagnosed with type 1 diabetes when already it's late. They're in a condition we call diabetes ketoacidosis. Now, this condition has a high risk of mortality or death. So the information we are sending out there is to the healthcare workers is when a patient comes with reduced levels of consciousness, with vomiting, with weight loss, with nausea and labored breathing, please check their sugars. Emily did mention that she was treated for pneumonia and malaria for some time before she landed in Kenyatta. Now, this is where we go wrong as healthcare workers, because when the child comes with labored breathing, we make a diagnosis of pneumonia. When the child comes with reduced levels of consciousness, we think of meningitis. When they come with weight loss, we think of malnutrition. When they come with vomiting, we think of gastroenteritis. When they have abdominal pain because of increased ketones, we think of acute abdomen and we call the surgeon. So we have to always think of type 1 diabetes whenever we see these symptoms and signs, and check the sugar. So that's basically how it presents.
Okay. And you've actually mentioned a very good point about misdiagnosis. And what actually causes this diabetes, especially type 1, at such a tender age?
It's a very good question, Zaiton, that you ask. Now, there's something we call genetic predisposition. What do I mean by that? All of us are born with certain markers on our cells. So these markers are helpful in identifying a virus or bacteria out there that tries to attack the body. So when this virus comes in contact with the body, the markers will pick them out and try to inform the cells to do what? To kill them, to destroy them. But there are some children who are born with certain markers that, beyond destroying the viruses and the bacteria, they go ahead to destroy the cells in the body. So this self-destruction of the cells, what we call autoimmunity. So some of the cells that get destroyed in the cells are the cells that secrete insulin. So we have some children who are basically genetically predisposed. Whenever they come to in contact with an environmental insult, like now the virus, you find that there's accelerated autoimmune reaction where the cells are destroying themselves, and so they develop type 1 diabetes. So any child can develop type 1 diabetes, even an infant of 8 months, a toddler, an adolescent, a young adult, and even adults can develop type 1 diabetes. Yes.
And talk about now type 2 diabetes, because can it also get to children?
Yes, type 2 diabetes can affect children, but it's not as common as type 1 diabetes. Which children are at high risk of developing type 2 diabetes? these are children who are obese. Because obesity, as part of the metabolic syndrome, increases insulin resistance. So you find that the action of insulin at the receptor level is not optimal. So as a result of that, now they develop what? Type 2 diabetes.
Okay.
But it's not as common as type 1. And we normally say any child coming with symptoms of diabetes, treat it as type 1 diabetes until proven otherwise. Yes.
Okay.
Yeah.
And for you, Emily, when you mentioned you were in ICU for almost 3 months.
Yeah.
What age were you?
3 years. Yeah.
In ICU?
Yes.
So how did it affect probably your growth and development after that? How did you come out from that?
By going to training in Kenyatta,
Training inakaaje sasa?
kufundishwa mambo ya kustabilize sugars, alafu nilikuwa na daktari pia alikuwa ananifollow sana. Jalango, Atieno Jalango alihakikisha kunifuata kabisa mpaka anaja mpaka nyumbani. Yeah.
So madawa
nilikuwa tu nimefundishwa, alafu nilikuwa na my brother ambayo was older than me, ndio alianza kunidunga mimi mpaka nikajijua.
Na in terms uli mention point poa sana because ulisema wazazi wako wanajua about diet, good diet. Ulikuwa unafaa kukula nini?
By then,
that time?
Mambo na mboga, alafu unajua walikuwa wanasema maybe mambo na brown food, na sisi hatujui. Furthermore, in Maasai land there's no balanced diet. Hata chakula hakuna kabisa. So ilikuwa tunakula chochote ambayo unaipata, then you balance with the insulin.
Okay. Sitat, siku hizi unakula nini?
Nakula healthy.
Unakula healthy foods kama gani?
Na avoid vitu za sukari.
Okay.
Na avoid mkate. Tunapika hizo mashed potatoes, sweet potatoes.
Okay.
Nakula veggies.
Veggies kwa wingi?
Yes.
Okay. Na sasa uko boarding? Uko day school?
Yes.
So shule pia wanajua diet yako ni special?
Yes.
Ama wewe ubeba kutoka nyumbani?
Wanajua cause shule si mimi peke yangu.
Kuna wengine?
Kuna watoto wengine.
Nao wanaendelea aje? Like how is their experience? Is it similar to yours?
Unajua kila mtu kuna venye mwili yake ina react different.
Yes.
Lakini sometimes tunakaga hivi chini. Tunaulizana yako asubuhi ilikuwa aje.
Mna compare notes?
Tunaangalia, tunamwambia wewe usifanye hivi. Fanye hivi.
Okay.
Sasa inatusaidia tukiwa watu wengi.
At least unafeel uko peke yako. Okay, that makes sense. Daktari, talk about diet. How is it an important factor when it comes to now patients dealing with diabetes, especially for children?
Okay.
Yeah.
Thank you. So management of type 1 diabetes is complex. But once a patient grasps it, it becomes very easy.
Aona venye Sitata anatuambia tu vizuri. Yani ni kama si complex, unaona? Ame learn the art of how to deal with it, yeah?
Yeah, so there are various principles
that
we normally employ when it comes to management of type 1 diabetes. Of course, because they don't have insulin, they have to take insulin. So how do we give this insulin? Insulin has to be given in multiple daily injections. So a minimum of 4 injections or 5 injections. Like Sitat here is using 4 injections. There's one type of insulin he injects once a day. That is what we call a basal insulin, okay? And then we have insulin that he has to inject before meals, either 15 minutes or 30 minutes before meals, depending on the type of insulin that he's using.
Okay.
By so doing, we are mimicking how the normal body functions. But besides insulin, diet is very important. For children, we normally do not restrict food because these are children who are growing and developing.
Yes.
So we want them to grow tall, to have normal weight, and to also develop in terms of their brain capacity and puberty development. We should not have any delay in puberty. So how do we ensure that? We tell them the carbohydrates that you're taking should balance with the amount of insulin that you are taking. And that's why a nutritionist is a very essential component when it comes to multidisciplinary team management. So what the nutritionist will do is look at the age of the child, the weight of the child, and determine how many kilocalories this child requires per day. And then she will convert the kilocalories into carbohydrates and divide it into 4 equal meals in a day and into 2 healthy snacks. So those carbohydrates in breakfast, for instance, should match the amount of insulin that the patient is taking so that the glucose do not drop so low or they do not go high. So there has to be a balance. Now, the general principle in type 1 management is the child has to take a balanced diet. Okay. We need to take the carbohydrates. The more complex, the better, because they have a way of sustaining glucose at a stable rate. Proteins, the vegetables, the nuts, the milk, the water, all that as recommended by the nutritionist. The challenge normally comes in when a patient is perhaps advised you should not take this or that. Then it actually makes the patient desperate or miserable in management of this condition. However, we say they can take that bread, they can take that ugali as long as it's not overly processed, but ensure that it balances with the insulin. Yeah.
Wow, that is complicated. Na sasa nani alimfundisha kujidunga sasa?
Yes.
You teach now children?
Yes. So now I did mention about multidisciplinary team. Now, we have a doctor or a clinician who is part of the team. So the doctor will prescribe insulin and the dose. The nutritionist will talk about the diet. Then we have a very crucial member of this team called the diabetes nurse educator. So the diabetes nurse educator will basically get to know the prescribed insulin, sit down with the patient, and take the patient through on how to inject, where to inject, how to dial that insulin dose, and the angle at which to inject. Besides the site of injection, the nurse educator tells the patient how to rotate the injection sites. She also teaches them how to correct when the sugars are high and what to do when the sugars are low. The nurse educator will tell them when you are going for a trip, for instance, there's a special bag that you have to carry. It's a hypoglycemic kit that contains the glucometer, the strips, and some snacks, to correct the low sugars in case they happen. And then, having mentioned the glucometer and the strips, it's the role of the nurse educator to also teach the patient how to prick himself and check the sugars and write in the diary. That is the diary that the patient will be bringing to the clinic for us doctors now to go through and see how we can adjust the insulin according to how the sugars have been. Of course, the nurse educator has so much, including even being a connection between the school and the caregiver and also the hospital. But beyond the nurse educator, we have a psychologist and a social worker. Very crucial members. What do the psychologists do? This patient, he's been living with diabetes for the last 12 years.
Yes, mpaka
and
I accepted.
Yes, and truth be told, if you're injecting yourself 4 times a day, and before injection you have to check your sugars. So you're actually checking your sugars minimum 4 times in a day. Humanly speaking, you get tired, isn't it?
True.
So they have what we call diabetes burnout or diabetes distress. If it's not well managed, they can develop depression or anxiety or even go into substance abuse. So the psychologist now comes to work with this patient right from diagnosis all the way to ensure that they do not have mental illness. The social worker will work with this patient looking at the social environment at home. Do we have a dysfunctional family? How is the support financially? How is the school support? That is the role of the social worker. The other crucial member is the pharmacist, of course, to ensure that the commodities are available, and the laboratory technologist to ensure that we do routine tests to monitor development of chronic complications. So management of type 1 diabetes is not a one-man show. It's a multidisciplinary team, so that they are able to do it, to manage their glycemic control well. Of course, not to forget the caregiver, the mother or the father at home.
For sure.
And of course, that school teacher, the teacher at school, they're part of the team.
That makes sense. So hata shule teacher anakusaidia kudunga ama ni wewe tu?
Kuna nurse.
Kuna nurse. So unaenda lunch time ama break time?
Every break.
Every break. Alafu anakudunga unarudi. Yaani sahi wewe hata uogopi sindano. Okay, guys, we want to take a short commercial break. They'll still be here. We'll be back with more about diabetes type 1, type 2. We'll get to understand more. And if, in case you have any questions about the same, please feel free to send them to 0759434389. That is our WhatsApp number. And also on Instagram, X, at KTN Home, and at Zaitun, Ali_Zaitun. Yes. We are taking a short commercial break. We'll be right back. Welcome back. If you're just joining us, remember this is Health and Wellness. My name is Zaitun Ali, and we've been talking about children living with diabetes. So right here in studio, I still have Charles Sitat. He is a diabetes champion. I also have Emily Mankura, Director for Action for Indigenous Children with Diabetes in Kajiado, and Dr. Phoebe Wamalwa, who is a pediatric endocrinologist. So karibuni tena. It's good having you, and thank you, Sitat, for sharing your story. And then before we went on a break, Sitat had a question kwa daktari. Is there any, nikuulizie ama utauliza?
Just ask.
Nikuulizie, sawa. Is there any other type of, probably a pump or a way of managing it without injecting yourself every single time?
Yes, it's a good question that we get quite a number from, a number of those questions from the caregivers. Yes, insulin pump is in existence. It's actually there, and it's a very convenient way of delivering insulin. Because what happens is you just simply put in the settings and then into the algorithm, and the patient wears it and, you know, just moves around with it. So it will, in a closed loop insulin pump, what happens is it actually measures the glucose. So there's continuous glucose monitoring. And then it sends instructions to the pump, and the pump calculates how much insulin to deliver to the body. So the patient will just move around with his or her own activities, but the pump has taken care of that. It's there. Even in our setup, we have a few patients who are using the insulin pump. The only downside is the cost and also the maintenance.
Okay.
Yeah, because you're talking of an insulin pump almost to the tune of 1 million. And then the cost of maintenance per month is around 50 to 80,000. So we are hoping that the insurance will be able to take it up to at least alleviate the work that goes on in management of children living with type 1 diabetes.
Sitat, you'd like to try that?
Yes.
How has been the medication and treatment so far? So right now, so it's been 12 years now.
Yes.
How has the medication and treatment been for you?
Not quite good. Because I get sick, I miss school, like for 2 weeks or something. I come up, I'm trying to catch up, but I'm behind. Yeah.
Oh no. And you're talking about seeking medication elsewhere.
Yes.
Why did mom and dad had that option of you going to seek a medication and treatment outside of the country?
They came to a conclusion and said that I should go and seek further medication, interact with other doctors, try to know how other people beside me, how they are living with diabetes, how they control.
Yes.
Yes.
Okay. So what do you think about that?
It's good.
You want to try it?
Yes, I want to try.
Na shule sasa,
I'll still catch up.
you will still catch up.
Yes.
So far, how's your performance?
In school, it's okay.
It's okay.
Yes.
And the other friends of yours who have it as well?
They are okay.
Yeah.
Yes.
Hata hao kuna sawa na miss shule hivyo?
Yes.
Okay. But mwalimu anaelewa.
Yes.
Anakusaidia ukirudi kukatch up.
Yes.
Daktari, I've even come across another question, and someone is asking, is there like a treatment, a permanent treatment towards this diabetes, or it's a lifelong disease?
It's a common question we get, especially at diagnosis. Because you see, a patient is in shock, wonders, how am I going to inject this child? The second question is, for how long am I going to do this? But the answer is the destruction of the insulin secreting cells in the body is irreversible. So then that means that this child will have to live with insulin exogenously. So it's for life.
It's for life.
Yeah.
Emily, hadi wa leo
Hadi wa leo
unaendelea?
tunashukuru Mungu, maana we are fine. Tunaendelea, tuna maisha.
Okay.
Unajidunga dawa yako, unajua tu which time. Tunakaa na watoto, tunaambiana time is now. Utafanya ile kitu. Tunasaidia na support, moral support.
Na daktari, I think, is it that as they grow older with age, madawa zinapunguka ama bado ni ile ile, ina remain the same 4 times a day?
Good question.
Yeah.
Now, the frequency of injecting insulin does not change.
Okay.
Because, as I said, we are trying to imitate how the body secretes insulin.
Okay.
So we want them to live normally in as much as they're injecting themselves. However, there's a time during pubertal development when they are just entering puberty where we normally have a bit of resistance because of the sex hormones, the estrogen and the testosterone. So what happens here is these children require a higher dose of insulin during puberty. But beyond puberty, the dose of insulin may come down,
Okay.
but the frequency remains the same,
Okay.
4 or 5 times a day.
Okay.
Yeah.
Oh, yeah, sawa. Another question to you, Daktari. If a child is breastfeeding and is diagnosed with diabetes, do I have now to stop breastfeeding?
Very good question.
Yeah.
There are times we get infants who are 8 months, 9 months with a diagnosis of type 1 diabetes, and they're still breastfeeding. Of course, we know the benefits of breastfeeding. The benefits are immense. So we do not advise that they stop breastfeeding. We tell them to continue breastfeeding, but try as much as possible to make it regular.
Okay.
Okay? If they can breastfeed after every 3 hours, the better. For older infants, older children, they can breastfeed perhaps 4 hourly. Okay? So that you are able to match the timing of insulin with the breastfeeding. However, breast milk can also be taken as a snack. So this child can be given a normal breakfast meal,
Yes.
and then at around 10 a.m., they're given breast milk, which they don't require insulin, but it's taken as a snack. Okay? Then at lunchtime, they take a meal. At 4 p.m., they take the breast milk, which acts as a snack. Dinner time, they take the meal. So that's how you can actually manage type 1 diabetes with breastfeeding, but you do not stop.
Okay. Hi, there's another question. Daktari, my child is a picky eater. How can I ensure that they are getting the nutrients they need?
Yeah, so we have such a type of patients. The first thing we normally ask the parents is, how is the meal times at home? Is it structured? Or is it that we prepare food, put it on the table, and allow anyone to just come and pick and eat it from wherever? So as a parent, you have to ensure that you structure your meal times. When when children see you sitting at a table and eating that healthy meal, they'll also naturally develop a culture of eating a healthy meal. Having said that, you also do not want to give a lot of maybe juicy drinks before a meal, because these one tend to reduce the appetite and fill up the child. So give healthy meals, healthy snacks, regularize your meal times, and ensure that the meal on the plate is well balanced.
Okay.
Yeah, so it's a journey at a time, but it's doable.
Okay.
Yes.
Yeah, Daktari, they're coming in fast. Another one. My child is an athlete. How does diabetes now affect especially their physical activity?
Very good question.
Yeah.
We say type 1 diabetes should not be a limitation to number 1, schooling, to physical activities, to competition. These children should not just survive, but thrive. So it's part of the diabetes education at the point of diagnosis. So what we normally tell them is before they go to the field, they should ensure that they have that hypo kit or hypoglycemic kit that has a glucometer and the strips and the dairy, and also a snack, and also some fast-acting sugars to correct the low sugars. So before they go to the field, they measure their sugars. If the sugars are at a certain level, let's say less than 4, you have to correct, because that is low sugars, hypoglycemia. If they're between 4 and 7, they take a snack before they go to the field. If it's more than 7 and less than 14, they can go to the field. But 30 minutes into the field, into the physical activity, they must come back again and check their sugars, see where they are.
Okay.
If the sugars are low, they have to correct. So these children can actually live normally, competing, exercising, as long as they have a high pocket.
Okay.
Yeah.
Sita, tumepata sport ya kufanya ama activity. What do you like doing?
I play basketball.
Oh, you do?
Yes.
Oh, nice. Na siku hizi umejua
Congratulations.
kumanage, uchoki sana.
Yes.
Okay. That's good. Ingine wenye unafanya ni basketball tu?
Swimming.
Oh, you're swimming.
Yes.
Yeah, that's good. That's really good. Okay, let's come to now in advocacy in terms of children living with diabetes. Emily, talk about your foundation and how it's now helping the community create awareness about this disease. Yeah.
Our organization, we support children to access to diabetes care. So tunawatafuta kutoka mashinani, tunawapeleka kwa daktari.
Okay.
Ambao maybe kuna wale washapatwa na hiyo ugonjwa sukari, lakini they don't go to clinic. They buy medication from the pharmacy. So they are not well controlled their sugar. So we lead them to Kajiado referral to Dr. Wamalwa. Then once a clinic hapo, once kufuatiliwa.
Okay.
Yeah.
Any other advocacies that you do as an organization?
We support them. Mambo na balanced diet. Sometimes as organization we give them food when they are in their vacation. Tunawapatia chakula ya wastahimili hiyo muda ambayo shule imefungwa. Again we follow up, tunatafuta Kajiado government, tunawatafutia bursary. Kwa wale ambayo maybe wazazi wajiwezi kuwalipia school fees, maana kuna wale watoto the parents cannot able to afford medication and food and school. So tunatafuta tu jinsi ya kuwasaidia warudi shule, wapate hospitali na wapate dawa.
Okay.
Yeah.
Okay. And can one inherit it, like is it genetically inherited? Asa venye Emily ako nayo, is it a guarantee, God forbid, that probably her son or daughter can get this?
No, it's not a guarantee.
Okay.
But as I mentioned, there's some genetic element in type 1 diabetes, just like type 2. But in type 1 diabetes, you don't see so much like the way you normally see in type 2. There's some small percentage of increased risk of a child getting diabetes if the parent is diabetic. Okay? But the risk does not go beyond 5%. 5% is so small. However, when you look at our nationwide statistics observationally, you may find an occasional young mother with a small child.
Yeah.
Both of them have type 1 diabetes. An occasional family with 2 siblings with type 1 diabetes. Yeah, so there's that genetic component, but it's not as strong as type 2 diabetes, where you see a lot of aggregation of type 2 diabetes in one family. Yeah.
You have kids?
Yes.
Okay. Wako sawa kabisa? Wanasemanga aje wakikuona ukiweka dawa, ukijidunga dawa? Ndio uongo. Nice.
Daktari meona akashanga. My first born is in form 4.
Okay.
The other one in class 6. Sasa wao ndio kabla huyu was class 6 atoke, anakuja good morning mom, you're fine. Mkao kunywe chai ndio nisiende kutukoma in case sugar is down.
Hao ndio sasa caregivers wazuri zaidi. And are there probably, daktari, are there legal rights being put in place, especially for children living with diabetes?
Yes, they actually have legal rights. We have the World Health Organization that describes type 1 diabetes as a disability.
Okay.
But whether Kenya has taken that up, we are not quite sure about it. We have rights in terms of schooling, that every child has a right to access the best possible schooling or education. And so whenever you see a school refusing to admit a child because they have a chronic ailment like type 1 diabetes, then it's a crime, because their rights are well entrenched into the law, the constitution here in Kenya. So they should not be discriminated. They should be allowed to choose whatever vocation, the work that they choose to do, but of course in collaboration with the medical caregiver. So their rights are there. They're actually enshrined in various platforms, WHO, the UN, Children's Rights, the Constitution of Kenya.
Okay.
Yeah.
And we've talked about the treatment, we've talked about managing it, but now, is there a way we can just prevent it from getting to us?
Yeah, we have a lot of studies as we are speaking.
Yes.
A lot of studies that are ongoing in various places. What we are saying to these children, as the scientists will say, please hang in there, use your insulin. As the studies go on, the researches go on. Hopefully, one will come through, whether it is a transplant of the pancreas from wherever, we don't know. Okay, but yes. In terms of prevention, just getting the drug to give the child to prevent, that is yet to be gotten.
Oh, something like a vaccine?
No, we don't. We don't have that yet. But a lot of studies. Hopefully, we shall get somewhere. Yeah. So there's hope. But for now, sit at, hang in there, take your insulin. Okay.
Yes.
Lifestyle sasa, how can we just ensure our lifestyle liko in check to prevent probably getting diabetes?
For type 1 diabetes, unfortunately, we do not have measures to put in to prevent in terms of lifestyle like type 2 diabetes. For type 2 diabetes, we normally say ensure that you are physically active, you check your weight, you eat healthy, and then that one, of course, will reduce the likelihood of you getting type 2 diabetes. For type 1 diabetes, because the causative factor is different from type 2, it is really hard to prevent or avoid it. Okay, because remember we said we have some genetic markers that predispose them to getting what? Type 1 diabetes out of destruction of the insulin secreting cells. Yeah, but having gotten the type 1 diabetes itself, the lifestyle has to be optimal to prevent the complications that are related to type 1 diabetes. Which are these complications? Kidney failure, blindness, nerve damage, hypertension because of the effect on the heart, the stroke. So these ones can be prevented if we ensure that the glucose control is optimal.
Okay.
How do we ensure that it's optimal? Insulin compliance has to be in check. The diet must balance with the insulin. And then regular checkups and reviews with the healthcare practitioner, who will, every 3 months, will be doing a test we call HbA1c that looks at how the glycemic control is. And every year, the eyes have to be checked for any development of the eyes, for any development of any blindness. The kidneys also have to be checked by looking at what we call urine microalbumin. And of course, the doctor will have to examine if we have any nerve damage. So that's, and of course, the blood pressure measuring after every visit. So that way, it prevents development of chronic complications.
Okay.
Yeah.
Emily, are there any complications that you've experienced as a result?
Personally?
Yes.
No.
Okay.
No.
Okay. So at least it's you're managing very well.
Yes, but the children who are in my organization, they have complications.
Like which one?
Yeah, blindness, kidneys failures. Yeah.
How old are they? Unachukua watoto kutoka umri gani?
Yoyote tu yule ndio at least aweze kumfikia daktari.
Above 18?
No, from a month up to 35 years. Youth.
Okay. Yeah. Youth wote. Yes. Okay. And at least utapata support. The organization will continue creating awareness. And najua kwanza Umasaini, normally they have...
Umasaini kwanza hawapai watoto wafuatilie mambo na kliniki.
Sasa wanawatibu aje? Madawa za kienyeji. Kama gani?
Umetoka kwa hospitali, wanakupea the following day wanaanza kupika zile madawa za kienyeji, unaanza kukunywa. The next day uko ICU.
Sio dawa ya kienyeji ni nini unapewa?
Wanapika tu kama chai na kwa kama maji. Unaachishwa ile ya hospitali.
Iko na nini na nini na nini?
Madawa tu hizo za Kimasai. Yeah.
So there's no kuna dawa ya kienyeji yenye inaweza saidia
ama maybe waone kama
No. We don't have. And unfortunately, our children come late to the hospital because of that.
Oh no.
Yeah, because caregivers have a way of trying out this. And sometimes they come to the hospital, they don't believe you. So they will go back home and try that. And the effect is they lose their child or they will go elsewhere when it's already too late.
Those are some of the complications.
Yeah, so the only treatment to type 1 diabetes is insulin. We give insulin and manage the diet.
So, and to all health promoters, especially in Kajiado, so I think it's a very common disease, especially in Kajiado. So as health practitioners, how are we ensuring that we're creating more awareness in that area specifically, Dr.
Yeah, and I think this is one platform that we are using. Thank you, Zaitun, for having us.
Karibuni sana.
We also have, our, of course, the community advocacy group for Emily.
Yes.
I'm also the chair of Pediatric Endocrine Society of Kenya, and our work is to create advocacy, training of healthcare workers, and currently what we have been doing is we've been giving training to healthcare workers nationwide. By the end of August, we'll have done 47 counties, raising awareness on type 1 diabetes, how to make early diagnosis, accurate management, and how to prevent complications. Then we have healthcare promoters who have been given kits by the Ministry of Health, basically going into the villages to test the sugars, to screen in a way to get type 2 diabetes. But what we are telling the healthcare promoters is whenever you get a child with diabetes, please link them up with us so that we start them on appropriate insulin. These children cannot take pills. Their treatment is insulin. And then for healthcare workers, again, please, let's ensure that we do not misdiagnose these children. If a patient comes with labored breathing, check the sugars. It may not be pneumonia. If it's loss of consciousness, it may not be meningitis. If it's gastroenteritis with just vomiting, it may be type 1 diabetes. If it's malnutrition, it may be type 1 diabetes. If it's acute apneumonia, it may be type 1 diabetes. To the community at large, 3 classical symptoms of type 1 diabetes: increased urination, increased thirst or taking a lot of water, and weight loss. And to add on that, any child who had stopped bedwetting and suddenly starts bedwetting, that's a child you have to get worried of type 1 diabetes. Check the sugars. A child who did not have recurrent UTI and still now has UTI, has candidiasis, has skin infections or ear infections, those are children who may actually have type 1 diabetes. To the caregivers, to these children, please support our children.
Yeah.
Because they go through a lot. It's not easy injecting themselves 4 times a day and having to check their sugars. So we say when you get a child who is diabetic, then the entire family should behave as if everyone is diabetic. Because we should not put sugar on the table and expect that this diabetic child is not going to use the sugar when everyone else is using the sugar. So everyone should behave like they're diabetic, support them. Yeah, and then again, health system strengthening in terms of empowering the healthcare workers, financing, availing of the commodities in terms of insulin, and basically proper leadership and governance is my parting shot.
That is well put, Daktari. Where can they find you?
Basically based in Kajiado County Referral Hospital. But we can also see patients in private facilities.
Okay.
Yeah.
Okay. Thank you so much. Aye. Parting shots. Young champ. Tuambie.
One more thing.
Yes.
I would like to humbly request the United Embassy to grant me a medical visa so that I can go for medication.
Okay.
Yes.
Wamekusikia.
Wamekusikia.
Tuna hope at least ifunguke. And if there's an option also of being treated here, pia sio mbaya. Tutaaminia madaktari wetu kidogo.
Yes.
Thank you so much, Sitat, for sharing your story. You're so brave, by the way. You're so brave, and healing is your portion. ng'ang'ana tu pole pole, but I know you are a conqueror already.
Yes.
Sawa.
Yes.
Na pia uambie marafiki zako the same.
Yes.
Yeah. Okay. Parting shot, Emily. Tuambie na Kimasai hivi hata ukiamua tukienda.
Kile maybe naweza request pia,
Yeah.
if there is someone who is there need to support us, you can support us for these children to get medication, to get food, again to get transport to
Kuwapeleka kwa daktari.
kwa daktari. Sometimes hii inakuwa vigumu kwangu, niko na watoto wengi nataka kuwapeleka kwa daktari, lakini sina means ama sina funds. I don't have funds to take them. So whoever is there and watching us and you are able to support indigenous children with diabetes, we will appreciate. And
Mko kwa social media? Bado. So it's a website nayo?
No.
No, but where is it located?
Kiserian.
So inaitwa Action for Indigenous
Children with
with
diabetes. But we
diabetes.
have a pay bill number, so we will,
Waambie.
the KCB Bank pay bill 522
Ndio hii kamera yako hapa.
522 533, alafu account number ni 8,322.
Okay. Tarudia tena.
Pay bill ni 522 533, account number ni 8,322. We will appreciate.
Yeah.
Thank you so much. Majina ndio ngumu kidogo kutaja.
Usijali.
Asholeng, thank you so much Zatun. Tunashukuru sana kwa lugha. Asholeng KTN. Please mmetuuza, tunashukuru leo.
Karibuni sana. Thank you so much for coming. Daktari, thank you for the expertise as well. We've learned a lot. Guys, until next time, I hope you enjoyed the show. I hope you also learned just like I did. Find it on YouTube at KTN Home. Also, in case you have any other questions kwa Daktari, kwa Emily, how to support them, our social media at KTN Home, at Ali_Zaitun. Until next time, see you guys.